Oh, no, I want to. No, you like that?
Yeah.
All right, Mike, how am
I?
I? Am I good?
Just hanging down.
Yeah?
That's good. Go ahead, Steve.
Okay.
You're on.
Yes,
And 5, 4, 3, 2.
Hello, and welcome to today's program with the Idaho Federation of Families for Children's Mental Health. My name is Steve Gracie, and my guest today to talk about children's mental health and the mental health system in general throughout the state of Idaho. My guests are Jim Bao, the director of the Disability Rights Idaho, Ruth York, who's the new executive director of the Idaho Federation of Families for Children's Mental Health, and Linda Miller, who's one of the parents associated with a group called the Parent Network. Today we're going to be talking about these things, and hopefully we'll be able to convey to you some information that is relative to your family and to your child, and information that hopefully will be something that you weren't really necessarily aware of previously. In particular, what is the Disability Rights Idaho, and what does that have to do with children's mental health? What is the Parents Network, and what does that have to do with children's mental health? And of course, what is the Federation of Families, and what does that have to do with children's mental health? So we're going to start by just asking our guests today to give us a little information about them. Jim, can you tell us a little bit about yourself? What is it, how did you get into this? What is DRI, and what does it represent, and what does it do? That's a good question for you.
Okay. Well, Disability Rights Idaho is a private nonprofit, but we get federal formula grants to provide legal and advocacy services to people with disabilities. And as far as what does that have to do with children's mental health, in 1982, I think, Congress added a formula grant called Protection and Advocacy for Individuals with Mental Illness, and it covered both adults and children. And it gave us a number of jobs. The first job they gave us was to investigate instances of abuse and neglect that occurred in 24-hour care facilities. The second job they gave us was to protect and advocate on behalf of the rights of people with mental illness, adults and children. And then finally, they wanted us to do something to improve the system. So we call it systemic advocacy. And in that respect, we spend a lot of our time and resources trying to have a positive effect on public policy, like Department of Health and Welfare rules, or state statutes, or policies at state facilities and practices at state facilities and things like that. So since 1982, that's what we've been doing, and that's how we get involved in children's mental health services.
How about yourself, Jim? What about you as an individual? I know that you've been involved with the Consortium for Idahans with Disabilities for many years, and you have a connection within the framework of your own family and so on. What's your story, and how did you get involved?
Well, I first became aware of the issues that people with disabilities face when my younger brother was born when I was 9 years old, and he was born with Down syndrome. And this was long before there was an Americans with Disabilities Act or any type of legal protections for people. Kids were with developmental disabilities like Down syndrome were routinely excluded from school altogether. They were considered untrainable or unteachable. When they were in school, they were often disciplined by being locked in little coffin-sized boxes. So things were really kind of awful. And when I graduated from law school, I wanted to do something about some of that. So I became a VISTA volunteer, Volunteers in Service to America, and my project was with the brand new protection and advocacy system for people with developmental disabilities. And this was in 1978. Being a newly licensed lawyer, working on an area of law where there was pretty much no law, was really, really exciting and kind of addictive. So I've really never finished my VISTA volunteer project. It's,
Just one from there.
yeah, it's 40 years later, and I'm still doing that.
Still doing that. Well, because the DD side of protection and advocacy started in late
78,
70s,
yeah.
but the
mental health
illness
side
one
was early
86,
80s. Yeah.
86.
Sometime in the
Yeah.
80s.
So that's been one of the reasons that you've been involved as a personal family stuff. And
Yeah, well, I also have my adopted son has multiple disabilities. His high spinal cord injuries, quadriplegia, he has intellectual disabilities, epilepsy.
Mm-hmm.
So, and you know, like everybody else, I have family members who've developed disabilities, and it's just sort of that's been my career.
that's your career. Linda, you became part of the Parent Network, and I'm wondering how in the world you even found out about the Parent Network?
I found out in a backwards way, probably not the way you want most parents to find out about it.
Backwards is good.
I wrote a paper describing a therapeutic school that I wished existed in Idaho, or in the nation for that matter. And I sent the paper around. It's not well written. I've since tried to rewrite it and send out to more people, but I sent it to the 2 districts in the Treasure Valley, Boise and West Ada. I sent it to the State Department of Education, and I sent it out to anyone else I thought might listen and hear and see something in it. So from that, I was invited to be on. First of all, they needed stakeholders and parent representatives for the YES work, and from that I was invited to be on that committee. That's really the only thing that came out of that paper at this point. So.
Well, you mentioned the word yes, and we'll get into
Yes.
what that means in a second.
Yes.
Tell us a little bit about you. What about your family?
I have 4 adopted boys, 2 of them with mental illness, 1 of them with a severe mental illness. So I came into needing some kind of system of care and some kind of assistance.
Good help.
So.
And how do you feel so far about your involvement in the YES project and so on, this kind of stuff?
It's been exciting. It's been an education.
Yeah.
I think definitely where I came in wanting something that we're really years down the road, even now, years away from being able to implement, I wanted changes right away, and that's never the case as I'm learning, because it's a slow process to even just to bring people together and have a conversation, and then to break down barriers of ignorance, or even my own barriers even of ignorance. And I think there's been, as I've watched it happen, there's been a lot of things that have come out of this, and we are moving forward. I've been involved for 3 years now, and I have seen improvements. There are a few services that have rolled out, not necessarily the ones that I'm hoping for, because the ones I'm hoping for are those mid-level services that are more difficult to implement and require the private sector to come in and really and there needs
Make
to be
things happen.
Yeah, there needs to be some money involved, and folks need to make a living, and so
Yeah,
it's a slow process.
It's a challenge. Ruth, you're the new executive director of the Federation of Families.
Yes, I am.
And this gets to be your first event, I guess,
Yes.
of what we've been doing. So what can you tell us about your background and your family?
Well, what brings me to this work is that I have 2 adopted kids, and through that journey, they are now 18 and 21. We have mostly faced some really tough emotional behavioral issues that didn't necessarily come with any sort of clear diagnosis over time. And what we've faced is trouble getting services because we don't have clear diagnoses for our kids. But also the expectation that these kids, because there is not a clear diagnosis other than, there's a whole variety of diagnoses they throw out there, but they really have been expected through all of their schooling and interfacing in community to be typical, because they seem typical. They can talk to you like they're very typical. They could make excellent panel members up here and there. But there are challenges that keep them from really being able to function in life at the level that 18 and 21-year-olds are expected to. And this has just opened my eyes hugely to, first of all, the journey of many, many adoptive parents and foster parents, which is just something I had never come across in life before. And the profound needs to create some awareness and education for anybody going into that journey. We felt we were doing good due diligence, and do we really want to go down this road, and what will it be like? And we had no idea, and I wouldn't trade it for the world, but there is so much we didn't know. And sometimes I just crave a do-over with the information I have now, because it makes me very sad for things that could have gone better with my kids with early intervention and better services.
Sounds like a direction that you want to take the Federation in terms of information, education, and informing.
I think it's huge that we've got to create awareness. We have to create awareness at all levels. So parents need to be aware, but we've got to have our state and the stakeholders that we need to connect with to really understand that we can't blame our children for what their challenges are. We need to figure out how to support the children themselves and the families that are in the day-to-day trenches of them really trying to bring help. For me, what I have found over time is being able to just stay in those trenches and keep loving them and loving them and loving them has just been the best thing that I could do. But I would have craved some partners along the way that could have really helped their behavioral and emotional issues.
Sounds like you're going to be in a role where you might be able to do some of that.
I look very much forward to that.
Oh, good. Jim, when here's my ignorant question. So I'm a parent, I'm a family member, I've got some issue. What issue, what problem, what kind of thing would I, as a parent of a youngster, of an adolescent in the system, come to DRI about, or the Disability Rights Idaho? Why would I come to you? What things could you do for me?
So our services are all based on legal rights. So the first question we're going to ask is, what legal right is implicated here, and what's the remedy for the violation of rights? Now that sounds very lawyery, but in fact legal rights is pretty broad. If you have Medicaid, then you have a legal right to medically necessary Medicaid services. So if you're being denied those services, we could help you with that. If you're in school and you are entitled to an individual education plan, but you're being denied one, then that's a legal right that's been implied. If your child is being subjected to improper restraints or seclusions in school or in a facility or anywhere, that comes under our definition of abuse if they're improper, because they're dangerous and potentially cause injuries. So people with disabilities and people with mental health issues frequently have rights to services and to treatment, or to be free from things like abuse, neglect, unwarranted restraint, chemical restraints, and things like that, that in fact imply legal rights. So anything in that whole arena is potentially something that we could work on. We took lots of cases of Medicaid cases of children whose, when their community-based rehabilitation services were denied under Medicaid through the Optum contract, and we appealed those cases through the administrative process. We have helped parents whose children have been improperly restrained or secluded in schools, or who have been expelled because they're not following the behavior plan. So there are just lots and lots of rights of children with mental health issues that we could potentially address. Now we have limited resources. We get about 1,500 to 1,600 requests for representation every year, so we can't do that. And so our federal, most of our federal grantors require us to set priorities. And and we do this on an annual basis. So every year, starting in October, we have a set of priorities, and we say these are the cases we're going to take until our resources don't allow us to take any more. And we arrive at those priorities by looking at our own case histories, but also by inviting public comment and comments from parents of kids with disabilities and people with disabilities and agencies that serve people with disabilities. And so we're constantly in that process. So, we're actually pretty close to having shaped our priorities for fiscal year 2019 that starts on October 1st. But that at the moment that we pick up those priorities, we will start collecting information for the next year's priorities. So we're always collecting information from people about what should be our priorities.
Okay.
Another area, if you have a child who's in a juvenile detention facility or a child who's in a treatment facility and you suspect that they're being mistreated in some way, that's always up at the very top of our priorities. We never have a year in which abuse and neglect investigations aren't in our priorities.
And that's connected to the P&A part, the protection and advocacy part, right? Now, does the protection and advocacy part mean that people have to be institutionalized? Or what's your definition of an institutional for people to be eligible for your service?
So, our definition of a facility is that they provide 24-hour care and treatment. If it's a place where you sleep overnight, then potentially that's considered a facility. So, and it's not that you have to be in a facility to get our services, but people in 24-hour care facilities get priority. So we will expend resources on people in institutions, in group care, in 24-hour care settings, before we will expend those same resources on people who live in the community.
So are we talking about kids? Are we talking about kids that are under the age of 18 that
Yes.
could be eligible for assistance? So it's wide open in that regard.
Right. There's no age limit. And our services are actually cross disability. So all disabilities, all ages. We have 8 different federal formula grants that we operate. So
That's what I thought. It was like well, you mentioned seclusion and restraint and so on. And we were talking about Ada and your
West Ada School District,
right.
yeah.
And in connection, you both kind of jumped on that a little bit in the pre-conversation, I guess. But tell us about what you were talking about in terms of what that is about.
I learned yesterday that West Ada is training, even as we speak, principals. They're principals in trauma-informed principles or care, trauma-informed care.
Yeah.
So I'm excited to learn that. I think West Ada has been proactive in that regard and trying to get some better ideas in place in folks' minds and some better tools for them to use in working with children who may need to be restrained in some way or better yet, prevention for the need for restraints. So trauma-informed care is, I think, is a very important thing that's opening up, and so much more is being learned about the effects of trauma on the brain and the way that children think and respond and how reactive they are based on the trauma they've received. And so dialing down that reactivity with the appropriate affect that the adult comes in with in working with that child can go a long ways toward preventing there being a need for restraint or seclusion. So I do think West Ada is moving on this, and I'm impressed.
Sounds like one other thing we talked about, early intervention, something that things take place. The interesting part for me is when we're talking about early intervention being seclusion restraint that's not
early. That doesn't seem like early intervention, does it?
No. What would be early intervention? Ruth, I'm trying to put this in the. So we got this restraint and seclusion thing. We can do these kinds of things. So what are the other kinds of things that we're doing that are not?
Well, a big part to me is just this trauma-informed training that West Ada is doing is so huge. I've been connected to some national organizations who really focus in on early trauma effects and how this kind of training can help. And it's creating a very different mindset for the people working with these children, teachers in West Ada, or principals, parents, to understand that if we use all of our instincts for working with typical kids on a child that comes from trauma, we can so easily just continue to traumatize that child. And we're doing damage without having any idea that we're doing damage. And I mean, I can totally see how this played out in one of my children's life over and over and over. And so this is the awareness that we need in the state of Idaho, and it's really thrilling to see it beginning to trickle in here. Because for me, during my journey with my children when they were younger, I felt like I needed to go out of state to find the right kinds of help and mindsets to get me in the right parenting mindset, but to also work directly with my children. Mm-hmm. And so I think it's huge that we simply have to change the mindset of how we work with these kids and understand that they are completely at the mercy of their brains being trained into essentially like a fight or flight is the easiest way to say it, where they're not working from any kind of executive functioning up here, which kids don't have a whole lot of anyway. They're really stuck in a more primitive part of their brain, just reacting to everything by, do I fight this, do I flight this? And we've got to know how to bring them, we've got to know how to create safety for them in order to bring them through that and get them to become more functional and successful in life.
Jim, you're nodding, and I'm thinking, okay, seclusion, restraint, all these different kinds of things. Where are you going with that?
Yeah, so, trauma-informed care principles were basically developed in 1996 in Pennsylvania. So they're not new. Pennsylvania, over the course of like 2 years, almost completely eliminated restraints and seclusion from their mental health hospitals. Okay, so, and we're talking about mental health hospitals, so we're not talking about people with mild anxiety disorders.
Right.
We're talking about people with very severe and persistent mental illnesses. So if Pennsylvania can do that, why can't everybody else do it? And a lot of people just refuse to believe that it was that successful until, as you mentioned, in the last 10 years, we've developed a lot of neuroscience, which has completely confirmed that that the use of seclusion and restraint increases the frequency and the intensity of the behavior that you're trying to control. So the idea is of trauma-informed care is to do exactly the opposite. Now, it's sad that 20 years have passed before we're saying it's starting to take root in Idaho, because we've been trying to, work on getting facilities and institutions and school districts to reduce or eliminate their use of seclusion and restraint for a really long time. It is wonderful that West Ada School District has decided to start down that path, but the problem with seclusion and restraint in schools is that unless the district develops their own policies, there are no rules. Mm-hmm. So there are no federal rules and there are no state rules for schools. If you operate a treatment facility, there are lots of rules about restraint, how long you can do it and what types of restraints are allowed and how much training a person has to have before they do it and who has to authorize it. I mean, there are lots of rules. But in schools where we don't necessarily have people with that kind of clinical training, there are no rules and there's no required training. It's up to districts to develop their own policies. So we worked for years with the Department of Education to try to develop some state rules about it. But once the likelihood that there would be a federal statute on that went away, the will to implement the rules went away. So we're West Ada is the largest district in Idaho. So fighting this battle district by district, that's a really big
great
win.
start.
That's big one. Well, let's stay talking Idaho.
Okay.
So you mentioned, I don't know if we mentioned already, so we have this Jeff D. lawsuit that took place 30-something years ago is eventually now, after a series of consent decrees and so on, the latest consent decree created the YES Project, Youth Empowerment Services. And that is one of the things that you're involved with as
Yes.
a parent. Can you tell us a little bit about how your involvement and also what is
So,
involvement for other parents that might be there?
Department of Health and Welfare has included parents as stakeholders on these committees, which is, I think, has been very beneficial for the parents and for the department as they define and move forward with what are these new services going to be. I think they've done a fabulous job of listening to us. Most of the time, the things that we've brought up they've been able to be implemented and heard. There's been sometimes, and we talked about this earlier, about how things always get a little watered down over time when you implement things. But overall, we've been very happy with our involvement as parents. We make comments, we listen to what's going on, we try to keep up, and that can be difficult. There's quite a few different committees, subcommittees that are part of this process, and parents are involved on most, if not all of them. So.
Do you feel like your voice is being heard? And
We do. It's difficult for us sometimes because we're not professionals, so our minds aren't in that game all the time. We're out, we're parents, we're with our kids. Most of us have seen backwards progress in our own children's mental health has declined over the past. I mean, for myself, we've continued to have crisis. We've continued to go through various different family dramatic events, and so my involvement has always been with this backdrop of these traumatic things happening in our family at home, which are obviously a priority. Mm-hmm. So that has been a conflict for me and for a lot of the parents.
I think isn't that a pretty standard kind of thing, Ruth, for parents and families? How do you get involved when you've got crisis? Jim, I know that even in yourself, like you can't be at every meeting because something can come up at home in the family. How do you promote this?
Well, and I think this is where there's a great role for IFF and DRI, as we raise the level of awareness across our state with professionals working in this area in our state and legislatures, then that helps us parents be able to come and go some, because you just feel like you need to always be at the table representing here's what's really going on, and yet we do have crises all the time. It cannot be beholden on just parents to do what is right for the kids of Idaho. Because there will always be some parents who can be at the table at any given time, but almost all of them who really want to be at that table are going to have to go away from the table to handle family emergencies for weeks and months at a time, which I just feel like that's why it's just so important to get this conversation out more, so people really have an awareness, a compassion, and empathy for what's happening in the family setting. And we as the state of Idaho just decide that we don't want families to be in this kind of struggle.
Right, and it's, the struggle is in all different directions. I know that earlier we were also talking about one of the things that is, we talked about legislature and legislative things that have taken place in your work with SID and the consortium for those legislative issues. And one is, you're going to have to explain this a little bit because I don't know exactly what the legalese would be to talk about when somebody is in, say, emergency room, even if it's an adolescent, and they do something physical to a doctor or a nurse or something, and they're charged with a felony. What is that about, Jim?
Yeah, so 3 or 4 years ago, the medical provider groups like the Hospital Association, the Nurses Association, the Medical Association, they got together and they passed a bill that enhanced the penalties for assault if the assault is on a healthcare worker in the course of their carrying out their profession. So and we're not talking about aggravated assaults or batteries. An aggravated battery where somebody gets injured, that's already a felony. But what they wanted to make even the lesser types of batteries where people get shoved or grabbed or whatever, even without an injury, they wanted that also to be a felony because they were experiencing a lot of assault of people in their emergency rooms. Often these were drug-seeking, people who were there seeking drugs and then got angry when they didn't have them. So they were looking for a remedy to protect their folks. The problem is that when people who are in the midst of a mental health crisis, the not really in control of what they're doing, the likelihood that they might touch someone in an unwanted way and therefore commit a battery, and if it happens to be somebody in an emergency room or in a psychiatric hospital or even in an assisted living facility, if they're a healthcare worker, then they're potentially guilty of a felony. So we raised this issue in testimony, and legislators basically said, "Oh, come on! Nobody's actually going to charge people with mental illness with felonies for that. So, if it does become a problem, we want you to come back." And so we waited to see, and it's I don't have statistics, but I have lots of anecdotes where people who were patients in state psychiatric hospitals, at Southwest Idaho Treatment Center, emergency rooms, private psychiatric hospitals, in the midst of mental health crisis, have basically been arrested and charged with felonies under this new statute. And I'm convinced nobody intended that would be how this was used. And of course, when you look at trauma-informed care, we're taking people who are already in crisis, where their fight or flight response is already through the roof, and then we're going to re-traumatize them. We're going to handcuff them. We're going to drag them off. We're going to put them in a cell.
And then we're going to charge them with a felony
for
their reaction.
And even if they ultimately plead down to a misdemeanor, that makes their ability to rent an apartment, to get a job. It interferes with your ability to readjust to life and to have a recovery. So, and as we all know, if you're jobless, homeless, and so forth, the chances that you're going to wind up in the criminal justice system again because of a failure of mental health treatment is just enhanced and increased. And that's not good public policy, because we already know that we have far too many people with serious mental illness in our prisons and jails who are there for things that were at least in part, if not completely, caused by symptoms of their mental illness.
So let's get the scenario a little bit. So when somebody goes into crisis, a parent and their child is in crisis, where is the place where they potentially might take them? To an emergency room at the hospital, in which that would come into play, in which a parent would not be conscious that that law exists and that could happen. What does that do to a parent now that you know that? What does that make you think?
I know I've taken my children to hospitals when they were younger, but now that I have a teen who's capable of fighting back and would be triggered to fight back, has already sees the hospital as a place that triggers him, I wouldn't take him there.
Where would you go?
I keep my keys and my phone in my pocket at all times. I'd probably take everybody in the house, and that was under control, and we'd jump in the car and we'd leave. And we'd probably leave the individual home to de-escalate by themselves.
Yeah. So what's going on is like, rather than to risk the possibility of some sort of criminal charge for your mental illness, you would just skip it.
I would just, and that's, I know I'm being a little bit too transparent here, maybe at this point, but there really isn't very many alternatives at that point. So I need to do in our family life things that are going to keep that individual not as reactive. So I need to keep my affects low. I need to keep my responses at a minimum. I need to just be listening. And honestly, over the last couple of months, this kind of thing happens every day. Every day there's something that if I responded too badly could escalate to the point where I was calling police and needing for them to then take this individual somewhere. And really it's on me to be trained in something that that I've only picked up, this information of how to deal with this individual, fortunately from counseling, which is provided by Medicaid. He has an excellent counselor that I'm able to visit with. And so those kind of services for me are critical, really.
Yeah. That's that.
So,
and now one of them is, in some respects, because of the possibility of a felony or whatever. So that the emergency room is kind of closed off a little bit.
It is closed off. It was already closed off to us because I know that will re-traumatize my son. So
yeah.
And now it's further closed off. I really don't know. I think doing something like that, sending him to the emergency room for me would be saying, I've given up on him and I'm just keeping everyone else in the family safe. So that would be my reason, would be the safety of everyone else. And that's a very difficult decision to make. And
I think it's really important for people to understand these moments that parents have where they have to make these decisions. Which children in my care am I going to serve the most right now? And because I can't serve them all the same way at all. So do you take some and run to safety? And meanwhile, the one who's de-escalating, until he de-escalates, he can tear your whole house apart. And you suffer the consequences of that when you try and return back to family life. And your kids that you're trying to protect are always going to be traumatized in some way themselves, either by the fact that you're whisking them away from brother or sister who's out of control, and they know that, and they may be scared too, or they may be really worried about brother and sister. There's just so many ways in which this creates a cycle for every member of the family involved that can be really devastating to each person.
Is it that complicated of a fix legislatively?
Well, everything that you do in the legislature is complicated. The change to the statute doesn't have to be complicated. I already drafted a potential amendment, entered into some negotiations. I really think that the healthcare people want to fix the problem. The prosecutors are much more difficult to negotiate with on this issue. And if you don't get everybody on board, then you have your chances of succeeding with legislation are diminished. Last year I think that we were close, but the Judiciary Committee stopped taking new bills just when we were about to get our first hearing on it. So I'm hoping that we will be able to come back next year with some language that everybody can live with, and that we'll be able to fix the problem.
Okay. So that is a fixable problem in a way. I don't know if it doesn't necessarily fix the overall problem, which is what you were talking about.
We need mid-level services. So the mid-level services would solve part of the problem. The fact of the matter is, my son doesn't have really anything to do during the day because he really needs a lot more than just a weekly counseling. He needs to be in an outpatient therapeutic environment that doesn't exist in Idaho right now. The therapeutic environment for him right now is the home, is myself, and so I have to be trained in how to deal with his issues. So. Yeah, I think.
Well, it's like every parent.
It is like every parent, and that's what we've taken on as parents, and we do it happily, but we definitely need assistance.
Oh,
so
yeah,
and you spoke about the hospital. Really, they're moving towards being more trauma informed too. I hope, and I think that will go a long ways because really, when you see an issue that's polarized like this, any issue that's where there's polarization, the third alternative is always the best one. So not the one that people are fighting over. So the answer is just a better approach overall. And hopefully I have faith that those things will be developed over time as we're seeing.
Well, you definitely sound very hopeful about
that's what I'm hoping for. And I have had occasions where I have called the police and I've gone to the emergency room that have been positive, where the police have been able to come out and de-escalate, and that's because they're trained to do that. And when they are trained and when it's effective, it's been very helpful for our families. So I must say those things that are happening are positive.
And I think that as we look at the system itself as it's developing, and particularly the YES project stuff with the children's mental health, as you observe that from your perspective and your role and so on, and I know you have, what are you seeing as how positive is this YES project and the kinds of rollout and stuff and the requirements of here's the whole CANS assessment thing that's taking place for everybody to be able to access that system. Do you see problems with some of the stuff and how it's rolling out at all so far, or you think everything is looking pretty good?
Well,
you've been around, you've been doing this for so many years, man.
I mean, I think it's a really positive move. I think we're going in a very positive direction. Of course, there are all sorts of things that can happen that make it less effective, and where there's going to have to do lots and lots of work to make sure we don't go down those roads. But several things that give me hope. Recently, you were there too, we had a conversation with the new medical director for Optum, who handles Medicaid's mental health contract. And they talked about their new model for this. It was going to start with the person-centered plan, and that the services the child needs would not be decided on a CANS or on a diagnosis, but on the person-centered plan. I mean, the person-centered plan, of course, would be informed by these evaluations and things, but that once we have a plan, then that's what decides the services. Now, if they can actually do that, that's really the core of doing a wraparound in which we say this is what he needs when he goes to school, this is what she needs when she comes home, this is what she needs if she's going to go out and do social things. So if we actually incorporate real person-centered planning into this process and then we honor it, that could be tremendously, I mean, that could be just huge. That and changing the attitudes about how you handle a person who's in a crisis or having a panic attack or whatever, is those things are they're really keys to all this. And it's sort of, I've learned over and over and over again, there's a limit to what you can put into the rules or what you can get in a court order to make people do things better. You have to changing the rules is important, but you have to change people. You have to change attitudes. You have to get people who are convinced that it's not hopeless. They will respond to treatment. They will respond to a better environment. They will respond to structure. Recovery is possible. People can live their lives without or having to cure them or medicate them to the point that they can't participate in life. And that if we do it right and if we come at it with an empathetic attitude, this is possible. We actually know this now. I mean, there's plenty of evidence on it. There's research behind it. There's statistics about it. These are evidence-based practices that have real-world results. And I think that some of those things, the person-centered planning, the trauma-informed care, the wraparound attitude, if you really can get those things, get enough momentum behind those things that people believe in them, once you start to get results, then they're going to be safe. They won't just be pie in the sky. Maybe we'll do this, maybe we won't. But, that isn't about changing rules. That's about changing people.
Yeah.
Rules are important, but you still have to change people or the rules don't do anything.
There is something that came out of the discussion about the CANS assessment. From just 3 years back, we started to hear about that in our meetings, the YES meetings. And as parents, we were under the understanding that anyone would be able to, that a lot of different people would be able to use the CANS as an assessment tool. And the way that it finally came down and came out, the policies were that the independent assessor would be handling the CANS, and that would be the entry point for someone to get Medicaid services. So that's become a sticking point for a lot of parents. They have been willing to negotiate on some of that, in that the big sticking point was that now my child has to go in, retell their story, re-go through and work with a person that they've never worked with before, and this is the person that's now helping me access the system. And for especially for kids who've been traumatized a lot in the system, that's definitely a bottleneck. That's a barrier. And I know for my family, we've not gone and sought help in that way with the CANS, because I feel like at least my child with the most severe mental illness is beyond that point, where he's not going to go back and retell his story. He's not going to go back and submit to questions. If I can go and fill that out myself, which they're moving towards, and that is one of the changes that they did make, is that we only need to see your child for just a small portion of the time with the assessment, and we'll do the rest of the assessment with the parent, and that's helpful. But for my family, it's not enough. I'm not going to put my child through that. So unfortunately, that was a disappointment for me in the rolling out of the CANS. So I'm hoping that they continue to move forward to remove those kinds of barriers.
Yeah, barriers. That doesn't make sense to put a barrier up to take barrier down.
Yeah.
But how old is your son?
He is 16.
16? Okay. I didn't ask before, so we know what we're talking about. All right, so you've been when do you actually start in your role? Have you already started?
Well, officially I started. I just, July 1st, I'm full-time, and
That's when you're more, that's
yeah.
when you're thing.
yeah,
So,
but I feel like I'm in there.
okay, and so, and listening to the different things, and of course now you're going to step into this particular role. You were at St. Luke's still at this
No,
point? Or
no.
you were?
Yeah,
okay.
it was May
And
1st.
so your involvement in this has been going on as a parent and for many years as well. What are you seeing now? Because you're going to be stepping into kind of a different role, I think, with the YES Project and this kind of stuff. What are you anticipating? What do you see?
Well, what I see, what I'm hearing again today, what I hear a lot is that I do see that we are making some steps in the right direction. But as has happened before through the history that you've been able to share with us, it's very easy to lose that momentum and get bogged down in the barriers. And so we simply have got to be out there making sure that we're identifying these barriers to, here's this great assessment, but actually can't get my kid to do it. And it's not reasonable to ask them, so we need a different way into that sort of thing. I think it keeps going back to the awareness, the education we need to how to create helpful supports that truly can be taken advantage of. Now, when I was out of state for a while my son was an early teenager, I experienced a wraparound program. And while it wasn't perfect, the fact that it existed showed a commitment of that state and county that I lived in to really try and shore up the parent and to make sure that everybody was working as a team in this child's life. So my son's teachers, my son's coaches, anybody could be invited that was a big player in his life to be on that team, so that everybody, including the juvenile justice people and the counselors, were speaking together as to how are we going to treat this child? What's the come from that we're going to share? Because if, the coach is working with him this way and the probation officer that way, and, a child just can't navigate all those differences. So it created some consistency for the approach to my child, but consistency for my family as well. And we could trust that when he's off at school, they really get what we're trying to accomplish right now, and they're our partner in that. And so there was a lot of comfort in that. And what I've experienced in Idaho is that we're just more disconnected than that in the services that we're offering to kids and to families. And that, probation's going to talk at me from one place, and my experience with probation is a bit dated at this point, and I believe juvenile justice really working on some important strides. But there was just no wraparound feel because there was no true commitment to wraparound services. And I think that's where we have to really bring that family and professional voice to what is really going to make a difference for these kids. Not just like what sounds good, what boxes can we tick off, but what is really going to change these lives? What sorts of early intervention are going to redirect a child from a path that, I know with my 21-year-old, it's going to be so hard for him, who is a very bright, capable, lovely young man, to get his life on a positive trajectory after years of what really are small mistakes. Yeah, I got caught with weed, but they totally threw the book at me, and I ended up on probation for years, and then I wasn't super cooperative on probation, so then I ended up in juvenile facilities for months, and I didn't have normal high school. So while I managed to get my GED because a judge required it of me, thank you, Judge, he feels this incredible weight to, how do I go out and do what my other 21-year-old friends are accomplishing in my life? He doesn't believe that he's capable of that. And yet, that's just all the messaging he got throughout his years of trying to go to school and do what he was told or do what probation was requiring him to do. He just feels like he just failed over and over, and so he has no reason to believe he can be successful as an adult. And that's just heartbreaking. We've got to get to kids earlier and have them understand that what they're experiencing is not their fault. And we are here to support them and have them find those successful pieces of themselves.
Yeah, it sounds like a lot of the stuff that we talked about in terms of even the idea of the felony in the hospital and those kinds of things,
Right.
So when that kind of stuff takes place in anybody's life, I mean, it has a dramatic and traumatic effect, overall. And in particular, when we're talking about our kids with these kinds of issues.
How many strikes can you layer on these young people who haven't had a lot of life experience yet, and then they just go out into the world needing to be a successful 21-year-old, or at least an independent 21-year-old, and they're just carrying this very heavy burden into that, and not enough successful experience to know how to navigate that.
And that raises two questions, I think, in my head. The first one, which should be a topic for a different show, is the transition period when somebody is moving out of the children's mental health system into the adult system.
Yeah.
What is that gap there, and how is that filled? What takes place? I think a whole show probably should be just talking about that. But let's talk about crisis and crisis intervention, and talk about the state role in terms of crisis, like we talked about earlier, where we see a fairly strong, is that a good term, strong crisis response on the part of the state in terms of when those situations take place, and at what expense to have that versus additional community-based services and so on. Am I confusing you? What do you think, Jim?
So, we don't really have good mobile crisis services outside of the Treasure, outside of Boise. Mm-hmm. I mean, there's no mobile come to your home crisis people in Clark County or even some of the bigger counties. Mm-hmm. It's one thing to say we have mobile crisis units, but that doesn't imply that actually all the kids in the state have any access to a mobile crisis team or any type of a crisis team, or adults for that matter either. So, you know, in Idaho, it's still the case that if you don't think you can handle it, for most people, your only option is to call the police. And if you live in Boise and a few other places, you might get a police officer who's had CIT training. But I'm pretty sure that if you're in the Minidoka County Sheriff's, that might not be the case. Or I always go back to Clark County, but then there's only 860 people who live there. But you know, so I think it's a lot of us in Boise seem to think that the way things are here is the way they are in Idaho, and that's
right.
That's not the case.
We're a very rural state, and that really impacts the kinds of services that are available to people.
So I still think that that the level of crisis services we have, even at its best, is not very good, and it's not oriented toward bringing people with clinical experience into the home or into the school. It's still aimed at taking the child, pulling them out and sending them somewhere. Hospitals or the new crisis centers, or the police station or the jail or whatever, as opposed to we have somebody who knows how to handle crisis, who can do de-escalation, and they're going to come to your home.
So you have to be mindful that getting a child through a crisis is not preventing another crisis. I mean, so it's great to have that level of service. It's important for families to have somewhere to turn in true crisis, but it is just a de-escalation of one particular situation, and it's not going to affect the future of that child and family.
Yeah, I mean, we're very, very short on rehabilitation services for adults or for children, for that matter, in which people learn positive skills and have the opportunity to practice, real life skills to prepare for work if they're going to be able to work. We're really, really deficient on that, and we're really heavy on ways to punish people for coloring outside the lines or scaring somebody or hurting somebody, but we put the punishment first, and that pretty much guarantees that we are going to have to deal with the crisis again, or at least it increases the chances of that tremendously. So we don't have housing. That's a big issue for adults. If you don't have a place to live, then the chances that you're going to do something illegal go way up because you don't have any place to live, and because you're out there, the streets. You're on the streets. You're frightened. There are hundreds of things that can trigger your condition. So we don't have housing. We don't have rehabilitation services for community and independent living. We don't have maintenance services. We don't have people who come out and make sure that, you may not have committed any crimes, but you may also be afraid to leave your house and buy groceries. Unless somebody's coming out and checking on your refrigerator, those people, they go until something happens. They hurt themselves, they hurt someone else, they become extremely ill for lack of care. And that's when we finally do something. Kathy Garrett, who has been a mental health advocate for many years, she says, imagine if we only treated cancer when it reaches stage 4. You'd have a lot more stage 4 cancer, right? But that's what we do in Idaho for mental health.
Yeah, and that's where there's some inaccuracy in those kinds of numbers. So do you think that the YES project is responding to less institutionalization or so on, but more community-based services? And
I hope so.
That's what the direction is, and that's where it's going.
I hope so.
Yeah.
I hope so. Getting those mid-level services for me has always been a priority, and I see it as a priority for those that are involved as well, but it's a slow process. So,
there's other layers in there that I think about because, for example, I convinced my son to go sit down with somebody, Department of Labor program, that could expose him to various work opportunities so he could, it's a good program, so he could begin to get a feel, what do I like, what am I good at, so they could farm him out to some temp jobs, essentially. I believe it was like over 6 months or something. But where it all falls apart for my son and for my other child in school is it requires more effort from them than they know how to give. Like, nobody would reach out from the Department of Labor to say, okay, here's your next step. And okay, now Alex, do this. And he didn't know how to work himself through the steps. He didn't know how to find those steps. It felt overwhelming to him. So there's a great program that's out there that could be so valuable. And I know if somebody could hold his hand a little bit through it, that he could benefit from a program like that. But when it's all on the person to step up, here's your opportunity, now step up, and they don't know how to do that full independent step up, then he never even walked through the door to start the program because he didn't know how to get himself that far. And so I think we have to really look across our state at all the various services and look through that lens of, is this actually a friendly, accessible service to somebody who's got some emotional behavioral mental health challenges?
Super good question. I know some people would say that maybe are not informed about your situation or the situation of people with mental health issues. They might say, well, that's the parent's job to help him through, but they've got to realize that there's a disconnect there with, this is a child who is in a stage of life where he's supposed to be drawing away from his parents and being independent.
Right.
And so, and with the mental illness he has, there's already a disconnect with the parents to begin with. So just having that different attitude where what is the accessibility here? Really, what does this look like for a person who is experiencing mental illness?
Access and so on. Well, folks, in the last minute here of our program, I think that I want to just say that we've talked about a lot of topics that I think you've got a lot of fodder for the next series of programs like this. Maybe have them both back again and talk about some of this other stuff that we didn't really get a chance to talk to in our hour here. So I want to thank Ruth, Jim, Linda for being here today and talking with us. Hope that you got some information from us today that's helpful to parents and families out there that may or may not be listening at this point, but may tune in at some point. All these programs are archived, and you can find them at the Federation webpage for a history of all the different programs we've done and see them, including this one, and not today, but eventually it'll be archived as well. Check us out on Facebook, do those kinds of things with the Federation, and I just want to say thank you again for being here and sharing with us. I'm sorry that we didn't get to hit all the different things that we could have, but I think we had quite a few things, and I appreciate your coming today. So thank you very much.
Thanks, Steve.